welcome. And thank you, staff members here, Ron, for this delicious meal. I mean, we've been coming to kind of holistic conferences for years, and you know, it's nice to walk the talk and give us a delicious meal. On the other hand, is anybody from McGuff in the room? Because thank you very much for bringing the chocolate bars. I appreciate the Mr. Good bar. That was very good. You know, my mother used to say to me, don't do that, except for sometimes. All right, so it's my pleasure to be here, and I'll push buttons. All right, good. And, you know, this is a great thing. Hugh Riordan, who was a great mentor of mine and an amazing man, had the vision. And here we have Ron and the team continuing that with a new vision. This is the second annual conference. It's an honor to be participating. Now, so the goals for this presentation, which may or may not be accomplished in the time allotted. So please feel free to ask me for clarifying questions or email for PowerPoints, whatever you want. I like these as an ongoing discussion where we can learn from each other. But the goals are quite simple: to understand the role of insulin in potentiating chemotherapeutic benefits. There's a huge literature on that, and it's just when our colleagues say to us, well, there's no literature on vitamin C or something, and then you say, well, just go to the literature and look, and they go, gosh, I didn't know it was there. There's a lot there. Well, in fact, if you look at insulin, it's a huge white elephant in the room that nobody pays attention to. Increasingly they are, but there's a great literature. Understand the theoretical and the practical aspects of what I call corrective cancer care. And the point I want to make here, although I will tell you today about insulin potentiation therapy, IPT, that's really one of the arrows in the quiver. And anybody who thinks that any technique cures anybody of cancer is way off base, in my opinion. But it's nice to have sharp and good tools. But we're still fundamentally in a relationship with people, and we're in a supportive relationship. So I'll tell you a little bit about this corrective cancer care in general, and then encourage you all to begin to incorporate this, what the patients call side effect-free chemotherapy, in your practice. So I do have I disclaim that I have no commercial interests, et cetera, and no conflict of interest to be declared. And I was going to give you, you could do a whole lecture on how everything presented today in peer-reviewed scientific journals is not able to say that. So we're a unique group of people where we're really here looking for the benefit of the patients. And it's hard to find in peer-reviewed scientific journals authors who have no conflict of interest. Even the editors declared that about 10 years ago. So I do have one disclaimer or one confession that I have my biases, as we all do. And for many, many, many years, I considered this to be a dog. And I had a dog like this when I was a kid, and anything other than a dog, especially those little yappy things, I thought were not dogs, and I saw no place for them. How many people own little dogs? So I now own a little dog. My daughter Amelia wanted a dog. She's the youngest of 4 daughters, and she found this dog in Missouri on the internet. Some nice gal who was raising these Lhasa Apsos. You know, we fell in love with this dog right away. This is like a cat with a dog body. It's a perfect blend, and for years I had nothing but disdain for those little yappy things. So this is an example of sharing with you that, like all of us, we open-minded doctors, I have some big biases. So part of sharing with you what I'm doing is that you can come back and say, there's a blind spot there, Brad. This is the new puppy syndrome. I don't know if you can see that. But anytime you start something new that can be messy, and here's Rory with the toilet paper he got a hold of. And this is, speaking of quality of life, we know about pets, there's pet therapy, but here's Amelia with Rory. This dog likes his nose in the air. And you know what? I say to my cancer patients, on the drive home, stick your nose out of the window and see if you can enjoy the ride more. So corrective medicine and psychiatry is really an American version of ortho. Everybody knows ortho means correct. And I like to I like to describe this as a fourfold process. So the logo we have at the clinic talks about the four human bodies: the physical body, the biochemical, the etheric or the chi, the second body. Rudolf Steiner talked about the third body being the soul. People have to have fun in life, and the spirit, a sense of purpose. So I always, as part of my work, I get permission from my patients to address those four levels, and I think that's important. It also comes from my initial training as a psychiatrist, where we had the luxury of at least an hour with a patient. I mean, how many internists had that? So we have this chance to do that. But I did want to make sure, because sometimes I get so excited I forget to thank people. So I do want to thank everyone for coming here. It's not easy to be outside of the box. I congratulate you all. I congratulate the staff here, and it should be said oftentimes how appreciative we are. Here are some of my mentors and friends. You recognize Abram and Hugh. David Horrobin, extraordinary pioneer. The bottom row you may not know. Otto Wolff taught me most of what I know about anthroposophical medicine, and Rudolf Steiner in the center was the teacher of this. Is a fascinating study, anthroposophical medicine. And on the right, I spent time with Tenzin Chodrak, who was the Dalai Lama's physician. I was in Dharamsala before Tenzin died. And when the Dalai Lama wanted Tibetan culture to thrive, he sent the physicians to American universities to give demonstrations. And I was fortunate enough to go to one of those, and I watched Tenzin Chodrak basically diagnose a pancreatic cancer by smelling the urine and holding the pulses. And he was accurate through translation. He was accurate with his diagnoses. So this was, for me, a great reminder that medicine, if you can do this by smelling the urine and holding the pulses, medicine is a lot more mysterious than we give it credit for. So if we can remain humble in this process, it's of benefit. And my best teachers, again, these gentlemen aside, are the patients, of course, who we can listen to. Because we're talking about cancer, it's just important, and again, I wanted to include this as an appreciation for you all being here. Here's Nat Morris in 1958 saying, "A physician once told me that nothing arouses so much bitter enmity and heated arguments among his colleagues as does the subject of cancer. This may be due to the guilty recollections of cancer victims expiring who might have been saved, or of memories of patients pronounced hopelessly ill who recovered under the treatment of a quack, or who miraculously lived without further treatment. Possibly these guilt reactions and the remorse over the exhausting of the money of patients and their relatives in futile cancer treatments accounts for some of these psychological manifestations from our conventional colleagues, which are expressed in hostility and attack." It's a great little synopsis, almost 50 years ago. I believe every physician out there gets out of bed in the morning first thing trying to do the best job they can. And if you're up against the treatment of people suffering with terrible cancers, this is a good little paragraph reminding us that those oncologists who are attacking us and critical and closed-minded are also suffering. So I shared that for that reason. Now, Bill Gates, I was going to say my friend, but I'll just say my neighbor up in Seattle. Bill is an extraordinary fellow who's done a lot of good in the world, and he took a lot of risks in life. Albuquerque, New Mexico, February, make that December 13th, 1977. I never got from Bill the story here, but the point is we all take risks, and sometimes they pay off. That's a mugshot. Quality of life has to remain our objective throughout. And I thank Ron for bringing that title to me in this regard. And the simple way is it's not whether you win or lose, it's how you play the game. We all know that growing up. And yet we forget that. So I tell my patients my goal is to improve the quality and the quantity of your life. Paracelsus, the great alchemist and physician in the 1400s, said there are no incurable illnesses. There are only incurable people. And I think that's important because I don't treat cancer. I treat people, some of whom have cancer. And I believe our languages are one of our greatest teachers. And if we can use language well and be conscious of language, we can stay on track in some areas. So my staff, I encourage them when people say, what's your success rate with breast cancer? I say, we don't treat breast cancer. And I'm not going to compare a 20-year-old with breast cancer to a 50-year-old who's alcoholic and bitter and divorced or whatever. You can't compare people. in my opinion, or I have difficulty comparing people who have cancer and having any statistical significance come out of it. So I just want to make the point that I try to treat people. Let's talk about this insulin. Of course, it's not just bacon and hockey players that come out of Canada. Insulin was invented. It's back to you, Stephen. Insulin, of course, was isolated in 21 by the great Canadian scientists, and Lilly took it over a year later, was manufacturing it. But look at that, 4 years later, a Mexican physician, Donato Perez Garcia, was using insulin intravenously within 4 years. And he started initially treating infectious diseases. So he was born in 1896 and died in 71, and he considered this a cellular therapy, and he was treating malaria and syphilis and poliomyelitis before focusing on cancer. Then his son, who watched his father be demonized and stigmatized by medical colleagues, took over the practice, said nothing. It wasn't until the grandson taught Stephen Eyre, Donato Perez Garcia, still alive today, taught Stephen Eyre, a great colleague initially from Canada, open-minded, and then now working in Chicago area. And Stephen started learning about the practice of insulin potentiated therapy in 1975 and taught me in 2001. And so I'm one of the few doctors who practice this and are certified to teach other doctors about this methodology. He wrote his book, and he talked about initial work being done with dogs with anti-syphilis drugs, also using mercury at the time, and he was giving himself injections. So I'm not going to go into a lot of detail about the history, but it's pretty rigorous science, but it's superb clinical work. And I do have a video, if someone wants to see at some point, of treatments of polio patients. The founder, the senior Perez Garcia, treating polio patients with insulin potentiated therapy. So again, it wasn't until 46, 20 years later, that he started treating people with cancer. It was initially an extraordinary anti-infectious agent. Now, just to pause for a minute, at this point you should all be saying, well, of course. Just the way if you have a child with a fever, you think, great, a little fever, it'll kill the bacteria, but the child will survive. Too much of a fever is a bad thing. Hypothermia, hyperthermia, anytime you shift the human organism, which is a tremendously adaptive organism, out of its homeostasis, the human organism will survive. Parasites won't. Pathological cells won't. They become vulnerable in a hypo or hyper state no matter what. For all we know, hyper or hyposelenium might do it. But anytime you move the organism out of its homeostasis, the human being does much better than the pathological cells. In this case, we're just moving that homeostasis in terms of glycemic indexes, hypo and hyperglycemia. But in 1944, Time magazine article, Garcia was up in the San Diego Naval Hospital treating effectively malaria and rheumatic fever patients, and rather than taking up the scientific study of saying, what did you do, let's replicate it, the doctor said, gosh, we'd like to have him come back and do it again. And you know, science isn't that hard. I mean, when Pauling did his work, it was clearly written that it was IV and oral. It wasn't that hard to replicate that study, but sometimes it's more challenging than we're led to believe. So the timeline, according to the original Dr. Donato Garcia, January 46, first treatment of breast cancer, successful using IPT. I like this. Find a cure before I grow boobs. This is a very persuasive article. So let's just look at this. Conventional chemotherapy, you know, again, a lot of my friends are shocked that I'm using chemotherapy drugs. These are drugs I knew nothing about. I avoided like the plague. But practically speaking, they're just very, very sharp instruments. And if you know how to use them in an elegant manner, we don't need to be afraid of using chemo drugs. They are very effective at killing cancer cells. However, they have many cons associated with them. The pros, that they're powerful and they're effective. The cons are that they're powerful and they're effective at also killing you. And when you look at the average oncologist markup, it exceeds 400%, so it's expensive. And the effectiveness rate, the research shows it's 2.1%. Now, we'll go into that in more detail if you like, but it's not like it's a well-accepted and successful modality, conventional chemotherapy. The problems, of course, is that you have to give high concentrations to get a a result, and that there's very little tissue specificity, and there's multiple organ and tissue toxicity. And the other interesting thing, which should be really much better publicized, is that we have in a tumor the size of your fist, a tiny percentage of those cells are actually stem cells and dangerous. The rest of those cells, which make up the bulk of the tumor, are not particularly dangerous, will not metastasize, and are kind of just like bystanders. They can cause trouble by occluding certain vital organs, by taking up space. But the chemo and radiation do not kill cancer stem cells. And that was new to me about 4 years ago. So all you have to say to your patient is ask your oncologist if he or she believes that the recommended conventional chemotherapy will kill my cancer stem cells. And most oncologists now will say, actually, no, it will not kill your stem cells. So good to pay attention to that. There's this reference, Morgan, Ward, Barton, the contribution of cytotoxic chemotherapy to 5-year survival in adult malignancies, Clinical Oncology 2004. There's a 2% response rate to chemotherapy. Opinion, the overall contribution of curative and adjunctive cytotoxic chemotherapy to 5-year survival in adults was estimated to be 2.3% in Australia and 2.1% in America. To justify chemotherapy only makes a minor contribution to cancer survival. To justify the continued funding and availability of drugs used in cytotoxic chemotherapy, a rigorous evaluation of the cost, effectiveness, and impact on quality of life is urgently required. And of course, after the study, the NIH instituted its big study to cut down the use of conventional chemotherapy and to shift it towards holistic medicine. I'm seeing if you're awake after lunch. All right. Why do cancer cells resist chemotherapy? There's all sorts of reasons we don't have to go into. It's good science, but we do know that they do resist chemotherapy. And the reason I bring this up is that insulin potentiation therapy bypasses most of these cellular resistances. So what would be the elements of an ideal solution to this chemotherapy dilemma? Well, you'd want to develop a method of differentiating the cancer cell population from the normal cell population. We've seen a little bit of that with high-dose vitamin C. It's wonderful. To deliver lower doses of the drug more specifically to this vulnerable cancer cell population, and to maintain or enhance the chemotherapy cell-killing effectiveness in cancer cells. Not just to deliver it, but to make sure the cell can't resist with its multi-drug resistance genetic process. So what would be the elements of this? I bring this up because, funnily enough, and also to avoid the side effects. And each of these 4 elements of an ideal solution to the chemotherapy dilemma is addressed with insulin potentiation therapy. My nephew sent this to me once. I love this. What box are you thinking outside of? You know, I don't know where you are, but I'm somewhere in those boxes. So we're thinking outside the box with insulin potentiation therapy. This is basically the utilization of insulin. Again, it could be hyperthermia, hypothermia. Some of the work in Philadelphia in the 20s was hypothermia. But you're using insulin here to modify the endogenous mechanisms of malignancy. We're selectively targeting cancer cells, enhancing anti-cancer drug effects, and we're doing this with about 1/10 the conventional dose of the chemo drug. And because we're doing low doses, we can actually do kind of a plan A, plan B, plan C. We can mix and match, because a lot of what determines chemotherapeutic choices is, of course, the big concern about not killing the patient while you're killing the cancer. With low dose, biologically modified chemotherapy with insulin, we can mix and match much more effectively. And again, I've been doing this since 2001. And I've had one instance of a patient with some bad nausea, but that's usually treated with medications, compazines, and so forth. And I've only had one patient lose hair. So they call it insulin. They call it side effect-free chemotherapy. Now I'm going to go through some more science here. The insulin receptors and cancer cells. Again, this is part of the science which is kind of shocking. Most oncologists know what a PET scan is, obviously. I mean, we know what a PET scan is, but that's a sugar. That's a sugar-avid process. And so, and we know with Warburg's work with oxygen, and we know that cancer cells need sugar selectively, preferentially. So let's talk about the insulin receptors on regular cells and cancer cells. Of course, the number of insulin receptors on cancer cells is much greater than on normal cells. Insulin receptor count correlates with tumor size and with histological grading. So per cell, more insulin receptors show up to enhance the cancer process. And the binding affinity for radiolabeled iodine-125 to insulin was found to be 9 times as great in breast cancer cells than in normal cells, and insulin receptors do not downregulate as readily and can have 1,000-fold resistance to receptor downregulation. So if you're trying to fight cancer and you're ignorant about insulin and insulin receptors, you're missing a huge opportunity. Mammals have 100 to 100,000 insulin receptors per cell. Cancer cells can have 17 times more. In many ways, if you understand this, in my opinion, knowing insulin and knowing cancer cells and insulin receptors, it's in many ways a more defensible protocol to oncologists who are critical of what you're doing than a lot of other things because the science is so compelling. Insulin in cancer cells. Insulin stimulates cell replication. We know that. Insulin is produced by cancer cells. We know that because biopsy specimens produce insulin. And cytoplasmic B units of insulin has tyrosine kinase activity. That's an oncogene product. Insulin resistance increases cancer risk. We know that with our diabetics and so forth. We find elevated IGF levels, insulin growth factor levels, in these cancers, Hodgkin's, non-Hodgkin's, adenocarcinomas of the kidneys, cervical, uterine carcinoma, etc. You can read that. And treatment causes IGF levels to decrease. Okay, so we have some markers to follow here. Insulin and IGF-1 operate autonomously at the cellular level within tumors to promote tumor growth. This is again an example of how the cancer becomes divorced from any higher control mechanism. And the way that it does that is through these insulin receptors in part. And IGF-1 is the major anabolic hormone, while insulin regulates and provides fuel for this process. So, you know, fasting has always been beneficial for most any illnesses. Too much fasting is, only Mae West said too much of a good thing's wonderful. So fasting is good, but not too much. But, you know, you have to starve these cancers too. Rapidly growing tumors are more sensitive to chemotherapy than slow-growing tumors. We know that. And studies at George Washington University and the National Cancer Institute, MD Anderson, show that they've tested and proved that insulin does potentiate the effects of chemotherapy. So that's big data for us to know about. These studies have been done. Insulin does potentiate the effects of chemotherapy. Hence, the results of our experiments, this is from MD Anderson, indicate that tumor-specific growth stimulates hormones, can be utilized to overcome the cytokinetic drug resistance, overcoming drug resistance, thereby render subpopulations of tumor cells vulnerable to the lethal effects of cell cycle active drugs that otherwise would have remained inert to their effects and might have constituted a potential source of late treatment failure. Again, when I laid out those problems of why chemotherapy is ineffective, one of them is addressed here, and they show that insulin allows the chemotherapy drugs to be persistently effective. We have membrane effects, we have metabolic effects, and we have cellular differentiation effects in terms of insulin. And in the membrane effects, we see that insulin delivered prior to giving chemotherapy at 1/10 the dose improved drug penetration into the cancer cells. You can use lower doses to reduce the side effects, and you can shorten treatment cycle intervals. So instead of once a week, we can do it every day. Metabolic effects. Interestingly, you increase the proportion of the cancer cell being in S phase, which is the vulnerable phase. So if you want to set the stage, so to speak, for your chemo drug to be effective, you want to be having it delivered during S phase. And nicely, insulin does that. Who'd have guessed? Increase the rate of cell kill per cycle because of this. In terms of the cellular differentiation effect, excess insulin receptors and IGF receptors on cancer cells allow for this to happen, and this makes the cancer cells basically a sitting duck. Because other cells which don't have all these insulin receptors aren't going to be so affected by the insulin you give prior to the chemo. So it's really a targeting process. And there's relative sparing for that reason of the normal tissues. What I say to my patients is, imagine this Thanksgiving process where the lady might have cooked a big turkey, or the gentleman, a big turkey, and she's bringing it out to the dining room table, and just as she's bringing it out to her 30 family members who are all polite and grateful, in come 30 Hell's Angels, big motorcycle thugs who are hungry because they've heard about her Thanksgiving dinner. She can, with impunity, put that turkey down in the middle of the table when there's 30 polite people and 30 Hell's Angels. I hope I'm not offending, Gary, any of your Hell's Angels friends. I shouldn't generalize, but let's just assume that the Hell's Angels are rude and they're hungry. If she had poured Valium on that turkey on the way out of the kitchen, or some nauseating substance, she could put it in the middle of the table, walk away with every confidence that none of her beloved family members will be affected by that, because they don't get any turkey, right? It's the same thing with this insulin potentiated cancer treatment. You give the insulin, you set the stage so only the cancer cells, there's a famine in the land now, everybody's hungry. There's a famine in the body. All the cells are hungry. But the regular cell has one insulin receptor compared to the cancer cell with 17 in the case of breast cancer. Who's going to get that insulin, and who's going to be opening their mouth wide for whatever comes next, which happens to be 1/10 of the dose of chemo. So there's a sparing in that regard. There's other studies which show in vitro, after adding insulin to an asynchronous population of breast cancer cells, the S phase was 66% compared to 37% in the controls. Again, we're trying to get these cells into S phase, and this is more of a graphic representation of that. The normal cell on the left, and then we see that the resting phase for the cancer cell is diminished, and the vulnerability windows are increased after giving insulin. Of course, another benefit is what kills most cancer patients. It's not cancer, it's cachexia, right? So we increase appetite. Changes the pathophysiology of the fatigued and the depressed and the anorexic patient. Insulin stimulates appetite, results in weight gain, and produces euphoria. So now there's some references which are interesting to me, and I share them with you. This is just a selection. If you just type in insulin and cancer at PubMed, you'll get a blizzard of information now. Human breast cancer cells have 6 times more insulin receptors and 10 times more insulin growth factor receptors than normal tissues. Insulin enhances the cytotoxic, I love this one. Insulin enhanced the cytotoxic effect of methotrexate in human breast cancer cells in vitro by 10,000-fold. I'd be excited if it was 100-fold. I'd be very excited if it was 1,000-fold, 10,000-fold. This is quite recent. This is why oncologists aren't using this. This was only published in 1981. All right, pre-incubation of certain breast cancer cells with insulin resulted in increased intracellular accumulation of the chemo drugs and a concomitant increase in cytotoxicity. It bypasses the multi-drug resistance genes. We're looking at some colon cancer cells, 5FU. Pretreatment with insulin enhances anticancer function. Conclusion, these data suggest that insulin enhances anticancer functions of 5FU when it is treated before 5FU for the appropriate time in human esophageal and colon cancer cell lines. First the insulin, then the chemo, then less cancer. Published in 2007. I'm going to keep going through these. These are rather than go through them in details, I'm giving you hopefully the concept, and if you're curious or skeptical, I would refer you to the literature. But insulin, we talked about, fuels cancer. So the other thing at the bottom of this slide, I say to patients, once upon a time, or to my colleagues, once upon a time, if you came in with a big infection, I would give you oral antibiotics. Today, if you have an infection and you go to the emergency room and they give you oral antibiotics, when IV is available, much greater delivery system, much less toxicity, no GI upset per speak. It's kind of malpractice to give oral antibiotics when you could give intravenous antibiotics. In the same way, I think conventional chemotherapy will be considered a little bit silly compared to the insulin potentiated therapy, because you can deliver much greater kill rates to the cancer cells with much less toxicity. Summary, biochemistry of insulin cancer. Glucose is the only fuel that cancer cells require. Cancer cells have 6 to 17 times the insulin receptors. I'm being redundant here, so forgive me. But we see that insulin receptors and insulin increase delta-9 desaturases, which makes cancer cells more permeable. There's a lot of science which explains how this works. Now, insulin potentiation therapy is a chemotherapy-based protocol using insulin as a biological response modifier of the endogenous mechanisms of malignancy. That's what I tell the oncologists who call up and say, "What the hell are you doing to my patient?" That's a nice little line. In IPT, insulin is used to selectively target cancer cells with lower doses of chemotherapy drugs, enhancing drug effects on these cells, and at the same time effectively reducing drug-related chemotherapy side effects. So that's kind of the quick overview of IPT and insulin. I think fortunately all along the way we think that we're intelligent. And then I run into something like this in 2001 and I thought, I had no clue about this. So it's a very fruitful area, and it's not scary to do IPT if you do it in a protocol that we've all been taught. Now, we're talking about cancer, quality of life, and so forth. So I just wanted to talk a little bit about the nature of cancer. Most people would assume that cancer is aggressive. I was taught many years ago that cancer is not aggressive, and so I wanted just to share that idea. It's kind of an interesting paradoxical idea. Rudolf Steiner said, cancer is not aggressive. Cancer grows into a vacuum. When the patient has let his or her guard down, or is no longer the master of his or her domain, cancer will proliferate where there is no resistance. I thought that was an interesting metaphor. I don't want to blame patients. We have to be careful about that. But it's not for me, it's not an assumption that the cancer is the enemy. Like I was trained initially as a classical homeopath before I went into medicine. And we all know that the symptom is a healing gesture. Well, cancer is a symptom. Maybe there's a healing gesture there. Just the way Tom taught us that atherosclerosis initially is a healing gesture at the lesion site when you've got a low vitamin C and you have a deterioration of the endothelial lining. You bring in a little calcium and some lipids to kind of create a cast. I think we often stigmatize the illness when in fact often it's the wisdom of the body saying something else is out of balance. I'm just trying to buy you some time while you figure it out. So is cancer aggressive? Is it curable or not? Is it infectious? And what is the role of the mind-body? Again, my psychiatric orientation initially has me think along these lines. And the mechanism of malignancy, we talk about insulin and IGF operating autonomously at the cellular level within tumors, and this operation is free of any higher level of integrated control. And that's what Hugh Riordan was all about, that higher process of integrating the human being. This is the Center for Optimization of Human Excellence and Function. I mean, we can't just be focusing on the tumor, and for God's sake, we can't just be focusing on the DNA, in my opinion. Okay, so we're going to skip that. But we remember that nature does abhor a vacuum. Empty or unfilled spaces are unnatural as they go against the laws of physics and nature. And that's why I always have with my cancer patients, I always have the discussion about why do you want to live? Why should I exert or invest my time and energy into, well, I've been a schmuck for the last 60 years. If you can just cure me of cancer, I'm going to go back and be a schmuck. We have to have these discussions, I think, with patients. So there are those who believe that cancer is not the problem, it's an adaptive response to the problem, and toxic blood and tissue is the problem. I'll tell my patients about growing up in northern New Hampshire. Somebody always volunteered their back 40 for a garbage dump, right? I mean, someone had a backyard, and he says, look, if you give me $10 each, I'll give you my back 40, you dump the trash there. That's a very nice solution, because that means we don't throw our garbage in our front lawns all day long. But once a week, we take it to Farmer Jones's back 40. Well, in many ways, a tumor in the body is analogous to that. It's a wise thing. Thank God we have this localization, this centralization of the pathologic process, so the rest of my body can be relatively free. Again, cancer buys us some time to get to the root of the problem. And so metaphorically, if you want to get rid of the tumor, why not recycle? Why not consume less so you're making less trash? Because if God reached down and just took Farmer Jones's back 40 up to heaven and emptied it out, the town would find another place to dump it. And we see that all the time. Surgeon cuts off the breast and pats the woman on the back and says, "You're cancer-free. Have a good day." And says nothing about changing the environments which have set up the cancer in the first place. So within a year, it's in the bone, it's somewhere else. Now, this is the mushroom on the tree outside my house. If I were to knock that off with a sledgehammer, and would Gary pat me in the back and say, "Brad, you cured that tree of fungus. Hell of a job. I got to get one of those sledgehammers." No, because you wouldn't get the fungus growing like that unless the tree had a systemic problem. It's the same with tumors, in my opinion. So what I'll say to my patients is we do three things. We take down the cancer welcome sign. What might that be? I had a patient who came in literally and said, "How much vitamin C do I have to take so I can get rid of my lung cancer and still smoke?" Well, you know, there's things we do which invite cancer in. At least 40% of my patients really, when you get down to it, who have cancer, have serious doubts about whether they want to live or not. That's a huge cancer welcome sign. So unless you take care of the other two, if you just focus on killing cancer cells, I think it's self-serving, not serving the patient. The metaphor is that if you're in a sinking rowboat in the middle of the ocean, thank God that you can bail. That's a great thing. That would be conventional treatments or whatever. But if you're not going to find the hole and plug the leak, I'm not sure it's a wise strategy to even bail. Just maybe enjoy the sunset. All right, so here's the pyramid we work with. It's metaphorically, I try to say that 85% of what keeps people healthy, I call it the safety net: nutrition, exercise, and thought process. Above that, when there's failings of the nutrition, exercise, and thought process, we supplement or detoxify. Sometimes we use drugs or surgery. But every time we give a drug, I'm thinking, how can we supplement more effectively so they don't need the drug? And every time we give a supplement, how can we address the lifestyle issues so we don't need supplements so much? Nutrition isn't just what you eat, it's what comes in all the senses, whether it's, God, it's horrible. You know, I'm fortunate that my clinic is right next to a kindergarten. So while the guys are getting chemotherapy, they're hearing kids laughing in the playground. It's just beautiful. But 2 days ago, the new game I was hearing in the playground was, "The world is ending, the world is ending." You know, it was heartbreaking for me to hear this game. But you know, we see a lot of troubles in our adult life, whether it's 2012 or whether it's this or that or Y2K. And now the kids are playing games that the world is ending. So that's nutrition too. It's the thoughts that you let in. It's not just what comes in your mouth, it's what kind of music you're listening to. It's your environments. So when I say nutrition, exercise, and thought, that's nutrition. For exercise and also the supplements, I'm not teaching anybody about theanine and arginine and ginseng and melatonin and Avamar and vitamin C and turmeric and curcumin, and you know, these we know about, but it's worth reminding us. Supplements now, I'm talking about the nutrition piece still. Also, I have become very, very pleased with this whole soy product called Helin 951, which I read about 15 years ago, and I totally discounted. And it wasn't until I was at a conference recently, and Walter Wainwright, who's the fellow who put it together, gave me a DVD and stuff, and I was flying home for 5 hours. So I watched the thing, and I said, wow. So I have here some handouts. I don't have enough for everybody, but after the show, Townsend Letter article recently, after the show. That was a Freudian sex. So there's some information on that, but do your homework on the Helin, because it's a whole food, fermented product, non-GMO, organic, and just about everything a chemotherapy drug does, this stuff does as well. And so you have an additional handout on that. That's this product, the Helin. The NIH in 1991 spent $20 million searching for the anti-cancer properties in fruits and vegetables. They came up with 5 super compounds: isoflavones, protease inhibitors, saponins, phytosterols, and phytic acid compounds, and they're all in the soy product, all in the soybean. Curcumin we know about. Proteolytic enzymes, I use lots of Wobenzyme. Thanks for Gary for turning us on to that. The research is very solid there. There's superb science demonstrating the mechanisms of actions. It's a foundation for my practice. Vitamin D we know about. Vitamin C plus vitamin K3. We haven't talked about the K3 yet, but there's a symbiotic effect there. It's going through this to keep us on time. Mechanisms of action. High levels activate oxidative stress. silver bullet issue. You don't need to hear from me about the vitamin C. But here's what you do have to remember. In a lot of our treatments, if we're starting to make our patients anemic, let's not forget oxygen. Now, this, Robert Burke published in Medical Hypothesis 2007, I called him up. Dr. Burke, blah, 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 I read your article, fascinating how if you just give people oxygen, you don't have to give them Procrit. If you give them oxygen, it'll basically, normal baric oxygen demonstrates that renal tissue can be stimulated to increase EPO production via a simple pattern of oxygen breathing. Fascinating study. Dr. Burke, tell me this, tell me that. He says, first of all, I'm not a doctor. I don't even play one in TV. He says, my wife had cancer. We were going broke buying the Procrit. So I think he was a chemical engineer or something. So this guy's not even a doctor. He writes a superb article on oxygen. He said, you know what? I published this first in 2000. And I thought at least I'd get, insurance doctors calling me, to save money. This is great. We don't have to give EPO, go get out. He says, you are the first person to call me. It's been out there for 8 years. I should call him back and say, it's now 4 more years. Anybody else call you? So don't forget oxygen. It's very simple and very beneficial for many reasons. Specific nutrients given IV before the therapeutic moment when the blood sugar hovers. It depends on various people. We take people down to about often 40, sometimes 30 in terms of their blood sugar. So a lot of things we can give beforehand. That's nutrition. Exercise, nutrition, exercise, and thought. Exercise isn't just running up and down, it's also digestion. It's kind of doing justice to what you take in your system, I think. And then the thought process is critically important, and I'm always checking in on this with patients. Reasons for living, quality of life, putting off stuff that is nourishing to their soul versus doing it now. So let me give you some cases here. This gentleman came to me, 65-year-old. He has Hodgkin's lymphoma, had a big node here, and didn't know, but his whole spine was lit up with lymphoma. And his doctor said, don't worry, Hodgkin's lymphoma is one of the great success stories of chemotherapy. It'll be a year of hell and then 2 years of recovery, but then you'll be cured. Well, he didn't hear about many options, so he said, okay. He took 2 treatments. He said, I would rather die than take this treatment. And his wife heard about me, and out he came. And I just want you to see the timeline. The PET results before I saw him, February of 2010, multiple areas of abnormal metabolic activity seen in head and neck, abnormal metabolic activity seen along the retroaortic thoracic lymph node, and their skeletal lesions, L3 and L4. Impression, stage 4 Hodgkin's lymphoma, multiple stations of adenopathy, head, neck, chest, abdomen, pelvis. Bad scenario. Oops, wrong button. Proposed treatment. Okay, here's the bleomycin that they recommended. And then the conventional treatment course involved these things, vinblastine, cytoxin, adriamycin, and so forth. Terrible nausea. He said he'd rather die. So that was, I saw him in April. We did bleomycin, adriamycin, dacarbazine, vinblastine, high-dose vitamin C, HDVC, 50 grams in 450 of sterile water with magnesium sulfate. After, and then we did alpha-lipoic acid, separate bags, so 3 bags, IPT, vitamin C, then alpha-lipoic acid, and then intravenous homeopathics, which come from the anthroposophical tradition, and then oral supplements along the way. So I'm just going to tell you what we do with IPT. Patient comes in fasting, and we have ideally access through a port or something, but we do peripheral lines as well. And we do a finger stick, and the finger stick might be 120. And so we then push insulin. It's typically 20 units. It could vary. And what happens is you'll bring them from 120 blood sugar down to maybe 30. Could be 60, could be 50. But the issue is when they start to sweat, when they start to slur their words, you're getting close to that point where we call the therapeutic moment. You warn them that it can be a little uncomfortable, it can be a little daunting, a little scary to have this sense of doom with that famine in the land. And then at a certain point, you push the chemo drugs in succession. Then we push dextrose. So now we're rescuing that hypoglycemic event, and we encourage them to eat and drink. Typically within about 5 minutes, they're out of that kind of a doldrums. They're feeling fine, they're eating, and they would leave the treatment feeling better when they came in. Rare in my experience are the side effects of nausea and so forth. So it's a simple process of create the hypoglycemia, deliver the medication at a therapeutic moment, rescue with dextrose, because when the cells are opening wide with their cancer cells, that insulin opens up their mouth wide, and the chemo goes selectively into the cancer cells, but here comes the dextrose. Who gets the dextrose? It's that cancer cell. So as they pull in that extra dextrose, what are they pulling in? They're pulling in the chemo, 1-2 punch. So this gentleman, so we had a PET scan in the middle of April, impression, remarkable improvement since February, near a complete response. His oncologist said, my treatment has kicked in, which was kind of cute. And then the patient goes off the protocol. He says, near complete response, good enough for me, I'm a businessman. Back to alcohol and stuff, doesn't tell me. I have to, it's a whole other lecture of how I welcome my patients in my clinic, because we have some pretty clear understandings about, we're doing this together, and just the way I wouldn't tell you I'm going to give you, IV vitamin C and give you Valium, just the way I wouldn't do that, you can't say, yes, Dr. Weeks, I'll take supplements A, B, and C, and then stop taking one or add something else. It's always the patient's right to do whatever he or she wants, but if they want me to play with them, they do nothing unilaterally. And if you have to, I think we have to be careful about that. But so he stops this, doesn't tell me. Next PET scan in June, enlarged nodes. He freaks out. What happened? Well, I said, yeah, what happened? He was still getting IPT. Again, unless you address the foundation issues in terms of nutrition and stuff, he was feeding cancer again. So then he got back. He leapt back on the protocol. And then the last PET in August, no evidence of adenopathy, no focal lesions, no abnormal this, no abnormal that. Impression, no PET CT evidence for residual or recurrent lymphoma. That's case one. This is Rory, again, just to keep you awake. And it's amazing to me how I used to not think that was attractive. So anybody who are just big dog people, just spend some time with little dogs sometime. I like big dogs too. Case 2, Leiomyosarcoma, uterine, stage 4, mets to the lung, 51-year-old woman, onset at age 47, failed surgery, chemo, and radiation, basically Gemzar, Taxotere, all these agents, a lot of different trials, PET CT in January, innumerable metastatic pulmonary lesions, aggressive disease, tumor markers are sky high, CA 125, 173, etc. And everybody, then the doctor was shocked that it came back so quickly. Put your affairs in order. It would be unethical, said the oncologist, to treat you anymore. To his credit, I think. Corrective cancer starts in March. We give her Cytoxan. These are low doses, folks. Gemzar, methotrexate, high-dose vitamin C, similar protocols. PET scan in April. So what are we doing? When does she come in? March. So a month later. The innumerable bilateral pulmonary metastatic lesions have shown substantial decrease in size and number. None of these lesions shows a significant degree of metabolic activity. Abnormal pelvis, stable, no evidence of recurrent metastatic disease. And in July, same thing. No new lung metastases. So is it the IPT? Well, unless you think to ask, you wouldn't know that she'd given up a child for adoption 30 years ago and found her daughter and is reunited happily. What does that do for the immune system? So that's just a picture of her markers. I like to do my best, but I had a great pediatrics professor in medical school. I was a student, in comes a resident, Dr. Smith. I gave the kid penicillin and it cured his fever. And the old doctor said to the resident, you can't say that, doctor. All you can say is you gave penicillin and the fever went away. So we have to be humble about this, but it's nice to see the tumor markers dropping. There's Rory teaching us how to be happy. Case number 3, fallopian tube cancer with mets to the lung, 67-year-old woman. Breast cancer, 94, mastectomy, etc. And then back comes the cancer. Fallopian tube cancer in 2000, 6 years later with recurrence to the mets, 2008. CA 125 is almost 9,000, etc. PET scan interval worsening in May, persistent abnormal uptake, etc. She starts in June. She's getting carboplatin, cisplatin, Gemzar, high-dose vitamin C, alpha-lipoic acid. The alpha-lipoic acid in a separate bag has to be light protected. I don't worry about the clock, Steve.
Great. That's my job.
And then the homeopathics again, and so forth. And here come our tumor markers dropping from 9,000 down to 800. And this was in just recently before I left. And CA 19.9 from 98 cuts it in half. So there's progress, and she's feeling great. This is the original come hither look. We're out for a walk. Colorectal adenocarcinoma, 2006. He's a 65-year-old man. He had a mass protruding from his anus and blood in the stool, and he thought it was hemorrhoids. So he did nothing for 11 months. Saw his primary care doctor, digital rectal exam, large mass, stage 4 colorectal adenocarcinoma. December of 2007, so about a year after he was noticing this stuff, there's a CAT scan. And then March of 2008, he refuses chemo, took radiation, 28 rounds, and took Arimidex, and then comes for IPT in March of 2008. There's data on this, but basically his CEA starts dropping. He gets the IPT twice a week, mitomycin, leucovorin, and so forth, high-dose vitamin C. The CEA is dropping into nothing. He gets a colostomy, but he says he's still alive, active, and back to work. He had 5-FU, mitomycin, leucovorin, oxyplatin. We alternated these. He had some intron, intramuscular rectal ozone, and high-dose vitamin C, alpha-POC, etc. CA drops from 12, then 19, 15, and then less than 5, and it's been that way ever since. He's grateful to the pioneers of IPT. He says, attaches a record of my CEA results. IPT was very effective with no side effects and allowed my surgery to be minimal, and now I feel fine. I've been keeping track of the billing for conventional treatments. Total for surgery and radiation treatment is in excess of $150,000, but I do not have an exact figure. If I had accepted chemo and that was repeatedly thrust upon me, the bill would have been considerably higher. Just had a follow-up from him just last month. Health is still great. IPT was a lifesaver. For maintenance, he takes lots of minerals, vitamin C, gram a day, a lot of vitamin D, etc. Here's Rory imitating a rabbit. Now, okay, so let's summarize this then. We all know that the standard of care is subtherapeutic. Only 10% of conventional oncologists, I wish if anybody has this, I've heard about this, so this is really hearsay, I should be careful. You got this? Okay. Apparently, 10% of conventional oncologists say they would not, only 10% would take the treatments that they recommend. This is apparently a UCLA catchment study or LA catchment study. In contrast, 100% of the IPT doctors I know would easily take the treatment that we give our patients. Alexander the Great, I die by the help of too many physicians. Good to remember that. So corrective cancer care with IPT is safe, it's effective, it's cost-effective, and it's the longest continuous cancer chemotherapeutic protocol in the Western Hemisphere, 1926 to the present. It's credit where credit's due, right? It's a smart bomb effect. The excess of insulin-sensitive receptors on human cancer cells sets them up preferentially. It spares the regular cells. The synergy of insulin's membrane and metabolic effect, increasing that S-phase experience, is brilliant, very elegant. So increased efficacy. So why we offer beyond the standard of care therapies? Again, I tried to be articulate in the beginning, but I think all of us in this room should be congratulated for taking the courageous tract we've taken, some of us for many, 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 many years. So why do we do these things which are beyond the standard of care? Well, they're more effective, the patients are grateful, and there's more professional satisfaction. Quality of life. I always ask and I look for the patient's sense of appreciation. I think that's our biggest immune-enhancing cognitive process, appreciation. Ability to laugh and cry, to be curious, to participate in life, to walk the dog, appreciation. So here's Rory smelling some flowers, reminding me, because I tend to go from point A to point B. Left to my own devices, there's the walk, it's got to be accomplished, get back to work. It's great having a dog that says, no, we're going to go, look, I've got these tiny legs, we're going slowly. Okay, So one of my patients wrote this note: "Dear Dr. Weeks, after my amazing treatments at your wonderful clinic, I feel so fantastic that I think I can walk on water. But I know that you can." And I found a picture to go with that, because I think we all can walk on water. It's a question of motivation. This guy is trucking. So anybody who's curious about this, you're welcome to visit us in Seattle, and we'll have some fun. So thank you all.